HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
Today my guest is Marie-Claire Seeley, and we're going to be discussing dysautonomia and postural orthostatic tachycardia syndrome, or POTS for short. Marie-Claire is a clinical nurse researcher. She has a passion for reducing time to diagnosis for those with POTS by engaging in research and education of her peers. She is a founding director of the Australian POTS Foundation and is currently involved in research at the University of Adelaide. Marie-Claire became ill in 1993 after a viral infection and endured a protracted pathway to diagnosis and treatment of her own POTS. The diagnostic odyssey that Marie-Claire navigated now provides motivation for her clinical work and her research. Recognising the need for advocacy, she founded the Australian POTS Foundation in 2021. As a volunteer CEO, she leads the work of the foundation by highlighting the urgency for improved recognition, diagnosis and treatment options for all those Australians living with POTS. Hello Marie-Claire, and welcome to today's HealthEd Women's Health podcast.
Hi Terry, thank you for having me. I'm looking forward to speaking about POTS today.
I was really intrigued when I learned that I'd be chatting with you today because we're going to be discussing really interesting things like dysautonomia and postural orthostatic tachycardia syndrome. Now, that's a lot to say, so I'm going to be calling it POTS for short, and its connection with Ehlers-Danlos syndrome. Now, I think it's fair to say that POTS is a condition that often flies below the radar, but it can cause a lot of distress to those who have it. So it is really great to talk to you today about these topics: what causes it, how to diagnose it, and how it can be treated. But before we go there, Marie-Claire, can I ask you to tell us a little bit about your own career path and how you came to be interested in these particular conditions?
Yes, so I don't have a normal kind of pathway to where I am now. Like a lot of people, I've had a finger in many pies. The reason I've ended up in POTS, and I work both in advocacy, running a foundation, but I'm also a clinical nurse and a researcher. But that all really stems from the fact that I experienced the onset of POTS when I was around 24 years of age after a virus. At that point in time, in fact, it was the very year that the condition was named by Mayo Clinic in America. So at that time, we had no idea of a name, although doctors, as I'm sure you know, for decades and indeed centuries, we've had written accounts of a similar type of condition. And so I later on in life did my nursing degree. I worked through as an emergency nurse and then went into academia, a bit of research. And it wasn't really until around 2019-20 that I decided that I really should maybe focus on supporting people with this condition, because by then I was well and truly aware of how much this population has slipped through the healthcare net and how little information was getting out to people with the condition about how they might manage it. So that's a short synopsis of where I've got to. I finished my PhD actually last year, and now I'm a research fellow at the University of Adelaide, really specifically focusing on this condition.
Okay, Marie-Claire, so let's get down to tin tacks and get that information out there. Can you briefly explain what dysautonomia is and how it commonly presents in patients with Ehlers-Danlos syndrome?
Yes, so let's look at that first bit, dysautonomia, which is more talked about these days than it probably was even 3 years ago. Dysautonomia is not a diagnosis. I think that's one thing to be really clear about out there. It is just a description of the autonomic nervous system not functioning to capacity. And I think the really important thing for clinicians to really consider when they're thinking about this patient group is that fundamentally, the majority of what we assume in medicine and in healthcare is based on the premise that everybody has a functioning and stable autonomic nervous system. And we really have not catered for the circumstance in which the autonomic nervous system is not functioning. We consider it in the central nervous system. You know, we have a whole medical specialty that's dedicated to structural issues really in the central nervous system. And we consider it with almost every organ of the body. But we pretty much just fundamentally plow on assuming that every individual that we see in front of us has a normal functioning autonomic nervous system. And that is not the case. And it's not the case specifically because the autonomic nervous system is, the majority of which is small nerve fibers that are not myelinated. So these are nerve fibers that can be affected by inflammation, disease states, and so on. So it is reasonable to consider that there is a range of what we call dysautonomia or autonomic nervous system dysfunction. We do have a series or a range of conditions that fit under that umbrella in terms of specific diagnoses. There are multiple types. A lot of them are rare, actually. So we have some very rare familial autonomic failure type conditions. But one of the more common conditions, and there's a cluster of conditions around the orthostatic intolerance conditions, and the primary one that really we see is postural orthostatic tachycardia syndrome. Some of the clinicians listening will be very familiar with orthostatic hypotension, which is another form of dysautonomia, and it's clear to really point out that not orthostatic hypotension is dysautonomia. Some of it's medication-induced hypovolemia. But we do have people with autonomic dysfunction that causes orthostatic hypotension. So POTS is the majority of, well, probably the largest cohort of dysautonomia that you'll actually see out in medical practice. And it's reasonably common. We don't have the prevalence yet, but you know, the estimate is about 1 in 100 young women will develop dysautonomia or POTS in their lifetime. So POTS, like orthostatic hypotension, not all POTS, people with POTS have dysautonomia. We should be clear about that. It's a heterogeneous disorder, so it probably has several mechanisms which drive it, and POTS is the common endpoint, if you want, of the symptom manifestations. The majority do actually have autonomic disruption. And unfortunately, when POTS was first described and the criteria put in play, it's very specific diagnostic criteria, there wasn't much understanding that perhaps the people that they were looking at with this disorder had another condition. And because it's kind of new in our minds, at least, and it's coming to the forefront as a more common condition than we thought, and that's the connective tissue disorders. And there's a whole spectrum of them. We know about the rarer forms with genes, so things like Marfan syndrome sits on that spectrum of heritable connective tissue disorders. But there's also the other end of the spectrum, which is a range of disorders loosely classed really as the hypermobile spectrum disorders, and in there sits that hypermobile Ehlers-Danlos syndrome. And what we've discovered probably more over the last decade is that people with hypermobility syndromes, and specifically with hypermobile Ehlers-Danlos syndrome, they are likely to suffer on, you know, about 70 to 80% now. The research that's coming out, there's a very large survey that's just come out and shown that the majority of the people in that survey, over 9,000 people, had been diagnosed with a form of dysautonomia. So that was either postural orthostatic tachycardia syndrome, or IST, which is the inappropriate sinus tachycardia, or the orthostatic hypotension. And this is really an emerging field. I think around the world you're seeing an explosion of research in this area, and the realization that these conditions that we thought lived in discrete, you know, separate kind of areas actually are all connected. So people with heritable connective tissue disorders, or the hypermobile Ehlers-Danlos, they do tend to be hypermobile when they're young. That does tend to disappear as they stiffen up as they get older. They're more prone to injuries, but they're also really more prone to things like gut dysmotility, which of course your motility of your gut is driven by the autonomic nervous system. They tend to have a lot of issues with orthostatic intolerance, hence their diagnosis of POTS. And they also tend to have a predisposition to neurodivergence. And interestingly, we know in the neurodivergent communities, so in autism and ADHD, that those people are more likely to also have orthostatic disorders and dysautonomia. Why do these conditions cross over is something that we can't answer fully at the moment, but even back in the 80s, what they noticed when they were coming up with this criteria, and they're looking very closely at the vascular mechanisms in people with orthostatic intolerance, they discovered that when you put some of these women on tilt tables, their vessels in their peripheries wouldn't constrict in the way that they should. So their vasopressor function was not working peripherally, it was working centrally. So they would often get constriction, and in fact they would get migraine, they might even get coronary spasm. But peripherally out in their legs, that pressor function was failing. So that might have something to do with the connective tissue in which our autonomic nerve fibers sits. So maybe there's a mechanism breakdown between what our brain is trying to send in terms of neurotransmission, or even the receptivity of those neurotransmitters out in the peripheral area. But there is also this other side to what we know about these conditions, and that is that people with Ehlers-Danlos syndrome are far more prone to autoimmune diseases. So celiac disease is more prevalent in that cohort, lupus is, thyroid diseases are. And so if you've got a population that is prone to autoimmune disease, it is likely that obviously that they might develop a wide range of autoimmune disease that are subtle but may affect the actual nervous system functioning. And we see in Ehlers-Danlos syndrome onset of POTS frequently occurs after a viral insult. So Epstein-Barr virus was the one that we predominantly saw prior to COVID, and now COVID is really exploding the cases of POTS around the world. So that's a short synopsis of why these two conditions come together. We don't know everything yet, but what we can tell you is they definitely cross over. 70% of people with POTS have hypermobility syndromes. 70 people, or up to about 90% of people with Ehlers-Danlos syndrome, hypermobile type, will have autonomic disorders.
Marie-Claire, it sounds like it's a bit more common than many of us maybe realised. Should GPs be screening for it or routinely than they do?
Oh, well, I'm the CEO of the POTS Foundation, so I'm going to say yes to that. I think 100% we should be, because what we know from International Classification of Disease code data in the US, so they had a unique POTS code that was allocated back in 2022. So we've got a few years of data now from the US on POTS. And they were able to determine that the pre-COVID infection rate, POTS rate, was around about 1.7% of the population. So that's already quite a common condition. But post-COVID, so if in amongst everybody who's had COVID, that risk rises to 3.4%. So 3.4% is a very large amount of people with this condition. And then if you look at the hypermobility rate in those, the majority of them are going to have that background. So should we be screening for it? I definitely think so. And the impetus for screening for it is the significant and really tragic kind of reduced quality of life that we see in these cohorts. So this is not a mild condition. 58% of people who develop POTS have to leave their career or their education. That's a staggering statistic. 22% never return, so they remain unemployed or out of education. And we're talking about women between the ages of about 14 and 50, so prime education time, prime work, career and family development time. We looked at a comparative study in our research where we prospectively matched according to age and sex, so made sure that we're looking at younger women, and they were matched with a healthy population. We had about 200 of each population, and they were all in South Australia, so living in a similar community. People with POTS had a quality of life that was worse than every chronic health condition, including cancer, kidney failure, heart disease, heart failure, neoplasms. So it was a significantly reduced quality of life, and it was on par with multiple sclerosis, which incidentally is a condition that mimics POTS in terms of epidemiology. So female-dominated post-viral condition and a very poor quality of life. So it is really important that we start to screen to pick up those who might be at risk of this condition and to really be attentive to early intervention to make sure that functionality is maintained in these predominantly young women, but men also, and that they don't withdraw from society, education and social engagement at such a young age.
Marie-Claire, can I ask you maybe to go through some of the early warning signs or red flags of POTS or dysautonomia that GPs might see in their consulting rooms? I mean, the idea obviously is to try and diagnose this quickly. So what are the signs we might be looking for?
Yeah, I think it's important to think about the natural history of a condition. So looking back at the historical triggers, the difficulty with POTS is it comes with really heterogeneous kind of symptoms. I mean, and people describe those symptoms differently. We describe them in the medical field as orthostatic intolerance, but no patient comes to you with that, statement. They come to you with, I'm just not how I was. I'm fatigued. I can't think. I can't do my swimming anymore. I can't engage in social activities. So it is about delving into when these things started. One of the best questions I think to ask is, when did you last feel healthy? And take it from there, because one of the really red flag things is the onset triggers. So we're talking in young women particularly. So the mean diagnosis time for this age, for this condition, is about 23 years of age, but we see a lot of frequent onset around the age of 13 and 14. And often it comes either after a viral illness, and by the time they're often not very unwell with the viral illness, so they might have got a cold, got glandular fever, they may have been unwell for a week, they go back to school or work, and it's kind of a few weeks later that they really start to realise that they're just not functioning. And by the time they come to see GPs, they've probably lived with it for 2 or 3 months or even longer. And so it's about going back to when that time happened. You want to look specifically if people start talking to you about new onset migraines. So that's part of the mechanism of the orthostatic intolerance. They tend to get a lot of new onset headaches. If they're talking to you about gastrointestinal disturbances, so I've lost my appetite, I feel bloated, early satiety. If they talk to you about withdrawal from activities due to fatigue and low energy, they are all things that we look for. So the gastrointestinal, orthostatic intolerance, and withdrawal from functional activities. And then we try and find out, was there a trigger? And so puberty can be a trigger, and we're pretty sure that is one trigger for females around that 13, 14 years of age. Most commonly, it's going to be a virus. So I was unwell. I stayed at home from school for a couple of days, and I've never been better. I've never been able to get back to what I was like. Occasionally we see this from concussion, and typically more common in males, and particularly males playing high energy impact sports like AFL. And we sometimes see it after surgeries as well. And we do see it after extreme psychological trauma, not as commonly. That's about 1% of all the people we see, but no doubt if there are successive traumas in someone's life, multiple deaths in the family, that heightened state of stress can stay, and the person can then develop this postural orthostatic tachycardia syndrome.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
Marie-Claire, what practical steps can a GP take to assess for POTS in a standard medical consult? And are there any simple tests that we can do in practice?
Yeah, and this is probably where it's become really difficult for the primary healthcare practice to manage this condition. Number one, a lot of the data and the information originally has originated from the US, which has a very different healthcare system, and it's very tertiary healthcare based and, of course, private insurance based. Whereas we work more on a socialized medicine front. But unfortunately, because of that, there's been a lot of concepts out there. Well, only a specialist can diagnose this, and it can only be diagnosed on a tilt table in a tertiary healthcare setting. That's not the case, and we're really trying to change that narrative. Certainly, it's complex for a primary healthcare practitioner to look after these patients because it's multi-systemic, but they are best placed to at least undertake the first diagnostics tests and to institute some primary healthcare management, and then we can look for specialty care afterwards. So it's important to understand that essentially POTS is a heart preload issue. So not enough blood is returning to the heart, and that's through multiple mechanisms that can occur, but two primary ones is either absolute hypovolemia. So we do know from research, particularly at Vanderbilt in the US, that a large portion of people with POTS have a low blood volume compared to healthy controls. We think that is because of the kidney system is controlled obviously by the autonomic nervous system, and so that there is likely a disruption to that with the onset of POTS, and it means that they actually do not retain enough of their fluid. So they're not necessarily dehydrated, they have low blood volume. And the other way is that the small nerve fiber dysfunction in the peripheries means that even when they do have what blood volume they do have is not being pressed and returned back to the heart. So they essentially have heart failure, but from the lack of return of blood volume to their heart. And this means that they have a lot of problem with cerebral hypoperfusion. They'll get the tachycardia from that low blood volume. They get dizzy, exercise intolerant, and so on. So our management strategies are lifestyle ones initially, and they really focus on that primary core mechanism. Number one, to get some vasopressor function there. Now, the best way to do that without pharmacological intervention is firm ankle to high waist compression, external compression wear. That doesn't require people to go get medical grade compression from, some of our medical stores as you would use in lymphedema, which is very expensive, and a lot of young girls are not going to wear it, particularly to school. But we do have now a plethora, a range of active wear that is of some medical grade compression, so at least 15 millimeters of mercury or higher. There are brands in Australia that are helpful for that. We have Supercore, even 2XU. These are things that the young women can get from Rebel Sportswear. We know from research that the compression is best to be the entirety of the legs and up to the high waist, because a lot of the blood volume that is lost actually into the splanchnic pooling, so the lower pelvis, and so it's important to get some abdominal compression on there. That does give some support to the blood pressure, and it can lower the heart rate in these patients, which gives them a little bit more energy and capacity for their activities. So we have no other mechanism to support vasopressor function apart from the compression, and later on we can talk about pharmaceuticals. And the other thing is to really actively try and lift their blood volume. And most GPs draw back in shock when we tell them that the primary thing to do there is to salt load the patient. And, salt has got a bad rap for good reason. It's not great for our heart and for our longevity. However, the primary issue with salt is that it increases the blood pressure, and that's why it can be cause damage to our arteries. But this is a population that, number one, is young and have limited other comorbidities in terms of heart disease and so on. Number two, they generally have very flexible venous and arterial systems. So their blood pooling is one of their issues. So they don't have those stiff arteries at all. And number two, they have a low blood volume, and low blood pressure is actually their primary driver of this condition. So giving them salt is safe generally, unless they have, a congenital heart issue or something else that the GP needs to look at. And the salt needs to be a lot. If we just go tell them to start drinking a lot of fluid, they are of course just going to urinate that fluid out. And in fact, if we tell them to drink a lot of fluid, they're going to cause a diuresis. They end up with that kind of primary polydipsia, polyuria thing where they'll be drinking lots, peeing lots, drinking lots and peeing lots. So it's very important that we emphasize the salt, and the international standards for that are 4,000 milligrams of sodium, which is about 10 grams of salt, and that equates for the patient to about 2 heaped teaspoons of salt a day. Salt tablets can be used, but this population tend to have upper gut dysmotility, so problems with the autonomic control of the gut movement. And if you give them salt tablets, it tends to irritate the gut, and they can actually end up with gastritis. So we do recommend that salt is intaken through the dietary system, and you can use electrolyte drinks. We would recommend ones with low preservatives. They tend to be a highly reactive population, so you don't want lots of colors and preservatives. And also you don't want lots of glucose. And although hydration drinks require glucose for the true issue of dehydration, this is not a dehydrated population. This is a population with hypovolemia. So it is effective to give them salt drinks without glucose in them. And the reason we say that is because there is good research and evidence that shows that this population tends to get a reactive hypoglycemia to glucose. So if you give them carbohydrate loads, they actually dilate all their blood vessels, they drop their glucose, and they tend to get a lot of postprandial symptoms. So the diet actually advised for POTS is a lower carbohydrate diet with more frequent meals during the day to reduce that food load at one time to limit those symptoms that they get. So for the GP, management is all around that compression, volume lifting, and then we try and avoid the triggers, which would be heat. We tell them not to have long-standing, showers in long showers or hot baths. We tell them not to stand for hours at school, obviously, to try and, if they're not walking and moving, they shouldn't be standing still where they're standing, because that's where they're going to drop their blood pressure and probably have a faint. There are also medications GPs should watch out for. So SNRIs increase that sympathetic drive, and we try and recommend that they be reviewed for non-SNRIs for management of whatever condition the GP is managing with that drug. There are even oral contraceptive pills like the Yasmin pill that have diuretics in them, so they're a bit like spironolactone. That would be another drug that we would try and avoid, because these are drugs that cause diuresis. And so just look for some of those things that might be contributing to the orthostatic intolerance. In terms of diagnosis, which I probably should have approached first, so it's really important that one of the first things GPs do is rule out other conditions that may mimic the orthostatic intolerance or drive the orthostatic intolerance. So we want to rule out thyroid disorders that may be causing tachycardia. We want to rule out conditions such as malnutrition or anemia that may be driving a dehydration, maybe driving the tachycardia as well. Once we're sure that this patient hasn't got an acute illness, so they haven't got a virus, they haven't got an infection, they haven't got a thyroid disorder, then we need to look at really their symptom profile. So if you've got this widespread autonomic symptoms, and by autonomic we would be looking at things like they might be complaining of not enough sweating or sweating a lot or inappropriately. They often first come with these upper gut problems. So I feel full every time I eat. I can't eat as much. I belch, I'm bloating. And if you're ruling out all the things that may cause that and you're left with no real explanation, then really they have a functional upper gut issue that's often an autonomic driven condition. And plus your classic orthostatic, I'm tired, I'm fatigued, I feel faint, my eyesight grays when I stand up. One of the first questions I often ask when you get a myriad of things brought to you in the clinic is, how do you feel when you're standing in a hot shower for a long time? And often you'll get the answer, oh, I can't do that. I have to sit on the ground. And, you know, those kind of behaviours are normalised in some of these hypermobile people because they've lived with it most of their life, but it's not until it gets to this threshold of affecting their function that they come to you. And so we need to then, once we've looked at the whole picture, we can't explain what else could be causing this. We know it's chronic, so we should expect the diagnostic criteria requires that these have been symptoms that have persisted. They might be remitting and relenting, but they've persisted for 3 months or more. Then they're kind of looking like they're going to meet one of the orthostatic intolerance diagnosis. And then we get to the actual diagnostic procedure. And these orthostatic disorders are defined by the way the blood pressure and the heart rate responds essentially to orthostasis or standing still. And so most of them require an orthostatic test. And we do that, we call that the active stand test. So you would lay a patient for 5 minutes, make sure they're rested. Once they're rested, you take their blood pressure, heart rate at baseline, you stand them up, and then you stand them up and request them not to move around, because what we're trying to look at is if we don't compress the skeletal muscles, if we don't use the muscle pump by walking around, if we just get the patient to stand still, how does their autonomic nervous system control their blood pressure and heart rate? So you stand them up, you take their blood pressure and heart rate immediately they're standing up, and then you do that every minute, and ideally for 10 minutes. Most of us are familiar with the 3-minute kind of stand, or in a GP clinic, that's probably a 1-minute stand just to look for orthostatic hypotension. But really for POTS, you need the 10-minute, and that is because it's the chronic inability of the body to manage the blood pressure that results in this tachycardia. And research has shown that often that doesn't really show in some people to after the 5-minute mark. And so we give it up to the 10 minutes. And that means that it makes it difficult for GPs, and I can hear them all going as if we've got time for that. And this is where you can to do a thorough clinical history. So, and if the patient's coming to you with all of these symptoms and say, look, how about you go away and we'll come back and do a long appointment, and at a long appointment, either get a practice nurse to do the standing test or you do it. There is a very quick tool called the Malmo POTS score that's got 12 questions on essentially a visual analog scale. It's got a clear cutoff score that it's validated for POTS. You can have your nurse, practice nurse, give that to the patient or run through it with the patient, or you can hand it to the patient and get them to bring it back. When they come back and you do the standing test, you will be able to look at that score and go, well, they meet the score, they're over 42, which is the cutoff score. And on standing tests, you then look at the difference between they were laying and when they were standing. And what we're looking for, the diagnostic criteria, is 30 beats per minute heart rate rise from their lying resting heart rate to the stand test, and we want to see that sustained. So that means at least 2 recordings where the heart rate was at least 30 beats or more higher than when they were laying down. It is important also to understand that orthostatic hypotension is the drop of blood pressure in the first 3 minutes that is sustained, and that is a slightly different diagnosis. And orthostatic hypotension can be explained by medications and other conditions, and it is slightly different autonomic miscontrol. If their blood pressure doesn't drop, it's probably because they've got POTS, and with POTS you get the very high heart rate that keeps the blood pressure up, but the heart rate just keeps going up and up and up, and some of these people can have heart rates up near the 200s standing up. So that's how we diagnose it, and that's how a GP can start management of the condition.
Marie-Claire, many of these symptoms that you've discussed and described are common. I have to ask you, do you think many of these patients slip through the system because the symptoms aren't taken seriously?
Yes, I think they do. And look, I also want to put it out there that it's not uncommon for young growing adults to have orthostatic intolerance. And in fact, some portion of the population is walking around with orthostatic intolerance most of their life. And I would hazard a guess most of them have hypermobility. It doesn't mean that they're functionally impaired by that. A lot of young athletes, for instance, if they're swimmers, rowers particularly, can have orthostatic intolerance with that. The real key question here, and this is where GPs excel, I think, is this functionally impairing this patient? And that's the question that we want to ask, because we don't need to treat everything. We can certainly give advice for orthostatic intolerance for people who get it occasionally. But my concern is the amount of patients that come through clinics who do complain of this condition, get told there's not much going on, or you just need to go exercise more, which is rarely the cause of this condition. And then they stop asking, and you would be absolutely shocked by the hundreds and thousands, actually, of young girls, particularly, who never attend education after year 8 or 9 due to the severity of their orthostatic intolerance. I mean, this is no benign condition. This is life-altering condition. So, yes, I think we need to pay more attention to it. And I think we need to dive deeper into how much this is functionally impairing someone. And we need to make sure that we track that we bring them back and check in on them a few months later, because if they're going down that slippery slope, eventually they'll end up housebound and even bedbound, and it's a very, very long road to get them back from that.
Marie-Claire, you mentioned before specialist referral. What specialists are best placed to support the ongoing care of patients with these conditions? Cardiologists, neurologists, someone else maybe?
The answer to that question depends on the ideal world. What is in reality is quite different. So let me give you the context. In Australia, 80% of people diagnosed with POTS at this point in time are diagnosed by cardiologists. Is cardiology the best specialty? I wouldn't think so, but then the best specialty for these patients may not be the accessible one. The reason I don't think cardiology is optimal is because they will look at the heart only, and they will control the heart rate, and sometimes very effectively. They can certainly prescribe the medications that increase vasopressin function and that reduce the heart rate. But these patients have very complex multi-system problems. So they often have gastrointestinal dysfunction, which limits the ability to be compliant to things like fluid loading or keeping adequate nutrition. And a cardiologist is not best placed to manage that. And where they fail in management in specialist clinics, it's because of that inability to manage the really multi-systemic nature of the condition. I think ideally, this is a nervous system disorder, but as I said before, particularly in Australia, we don't have autonomic neurologists in Australia. That's a specialty in the US, but not here. And our neurologists, quite rightly, are focused on structural issues, and there's a lack of neurologists anyway. I'm sure all you GPs know that. And so when we're competing for that specialty in terms of conditions such as Parkinson's and MS, you're not going to get a POTS patient looked after in that setting. Ideally, I would think general physicians would be best placed to treat this in a specialty area, and on some occasions even rheumatologists, because depending on the level of the crossover of connective tissue disorders, certainly those two specialties are more familiar with systemic interactions of conditions. And, we don't just get gut function, we get bladder problems in these patients. We get a lot of allergy and what rightly or wrongly are referred to as mast cell activation type syndromes. But unfortunately, our siloed health system is not optimal for treating autoimmune diseases or diseases like POTS, which predominantly are multisystemic.
Marie-Claire, we're nearly at the end of the podcast, but for those listeners who want some more information, do you have any good websites or resources that you could recommend on the topics we've been discussing today?
Yes, so in terms of dysautonomia or POTS, I would recommend that you go to the potsfoundation.org.au. So we have a lot of resources on there for clinicians about how to diagnose. We've got information sheets. We do webinars, RACGP accredited webinars. And in fact, if you want to attend one of our webinars, we have one on September 25th, specifically on diagnosing and managing POTS in the general practice or primary healthcare setting, and that's RACGP accredited. The ctDNA, so the Connective Tissue Disorder Network Australia, is the website to go to when wanting to know more about this Ehlers-Danlos syndrome. You can also go to the Ehlers-Danlos Society. There's lots of information on those websites about how these conditions are diagnosed and the crossover of the many different types of connective tissue disorders.
Thanks, Marie-Claire. I'll be sure to put some links to those on our website so people could get to them easy peasy. Marie-Claire, if I was to ask you to distill all that wonderful information you've given us into a few key messages, what would they be?
It would be that orthostatic intolerance is not benign, and that because a condition doesn't result in acuity or death, doesn't mean that it's not impactful, and that it's really important for us to keep our eyes open for those red flags of autonomic dysfunction, which would be orthostatic intolerance, new onset migraine, gastrointestinal dysmotility or functional symptoms, and that there are management strategies, and that GPs are best placed for both diagnosing and implementing those strategies to try and prevent this functional decline that we see in a large cohort of young women.
Marie-Claire, thanks so much for sharing your time, your expertise and your insights with all of us today. You take care.
Thank you, Terry. Thanks for having me.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.